Welcome, everyone. I'm Jeff Folloder, CLL, SLL patient and advocate. We are absolutely live with CLL Society's Facebook Live event, Ask Me Anything, where we spend the next 60 minutes answering your questions with a CLL expert. And we are so lucky to have Dr. Richard Furman joining us today. There are no presentations. We encourage you to ask your questions on the Facebook page, if this is how you're joining us, or through the Zoom platform. This event is dedicated to your questions, so ask them early and make sure we get to them all. If we don't get to them, we'll figure out a way to follow up. Before we begin, I have a few important disclaimers to share. Nothing said today should be taken as medical advice. Any questions about your health and your treatment should be discussed with your healthcare provider. The information that you post on Facebook will be shared on a public forum, so please do not post or share confidential information. Without further ado, Dr. Furman, would you please introduce yourself for our audience?
Thank you. I'm Dr. Richard Furman from Weill Cornell Medicine, and I'm the director of the CLL Research Center here. And I'm very happy to be here today.
Fantastic. As you can imagine, we already have a ton of questions that have come in. And the first question that I've got on my list is one of the questions that I hear very, very often on our support groups and frankly, the entire CLL community. I'll make it simple. What are the criteria for starting treatment with CLL?
I really think that it's so important for people to remember that, these criteria were established a very long time ago. And the criteria were really meant to distinguish between patients who were really quiescent and whose disease was not progressing from patients whose disease was progressing. And it really wasn't meant to be an idea about how long can you delay treatment. A lot of patients think that the longer you delay treatment, the more time you get at the other end. And I really don't think that's true. In fact, some of us think there's actually clonal evolution that happens, and that the longer you delay treatment, you may actually have some bad genetic evolution occurring when the disease begins to get active, and intervening early may actually help limit that. So waiting too long can sometimes be deleterious. So the idea is that when the cells start becoming more aggressive, that's when you want to intervene. And that's really going to be characterized by when patients really start having a doubling of their white blood count in less than 6 months. And that's, of all of them, really a softer indication. So, I've certainly seen patients who might go from a white count of 40,000 to 80,000 to, 160,000, and then just stop at 160,000 over the course of 12 months. But, that's certainly one thing that would show that someone's disease is becoming active. The more important ones would be the development of big, bulky lymphadenopathy, the development of big splenomegaly, or the development of an anemia, and that's a hemoglobin less than 11, and the development of thrombocytopenia, and that would be a platelet count of less than 100,000. Those are really the classic criteria. And remember that the anemia and thrombocytopenia are really equivalent to Rye stage 3 and 4. There's also, B symptoms, so the development of basically fatigue, weight loss, fevers, and really importantly, when patients do develop those symptoms, they sometimes could herald that something else is going on. And it's important that those things do get investigated. And I want to point out, and I really do emphasize this, that when patients do develop fatigue or they develop sort of those other symptoms, it really is something that develops with disease activity. So when someone's first diagnosed with CLL and they have small amounts of disease, with low disease burden, you shouldn't have B symptoms. And the B symptoms would really, develop with either active disease or large tumor burden. And if you don't have that, the fatigue is going to be more likely due to something else. And the phrase that all my patients hear me say all the time. As we did a study, very tongue in cheek, 70% of patients with CLL report fatigue, but 80% of New Yorkers report fatigue. So of course, you can actually take that at face value.
I'm grinning because yes, I experienced fatigue as a CLL patient. But I also did 6.2 miles this morning at less than 14 minutes a mile. So I can probably blame the exercise for the fatigue.
Right.
This is great information to have, the markers, if you will, for when to start treatment. Are there prognostic markers that are out there that might be able to predict the time someone has before they need treatment?
So it's really important that these prognostic markers are really of very little use currently in the management of patients with CLL. And these prognostic markers really serve to provide a means for people like myself to get promoted. And that's really, they serve very little purpose for patients, but to generate anxiety. So when you have a large number of people who have a large variability in their time to progression, prognostic markers will give us an ability to predict how a population will do, but never the individual. So even when you have all these different curves, there'll be people progressing on the good curve before people progressing on the bad curve. And so that's really something that you always have to keep in mind. So regardless of the prognostic markers, we're still going to look at basically when someone progresses. Now, when I look at the prognostic markers, it's really most important to keep an eye on what is the endpoint you're looking at. So most of our prognostic markers predict time to needing treatment. So if someone needs treatment in 2 years versus 4 years, but everything is well in 20 years, does the 2 years of earlier treatment or earlier time to treatment make a difference? And the answer is probably not. So is that really an important prognostic marker? And in my opinion, no. So when I look at prognostic markers, what really is important to me are the ones that are going to predict for how someone's going to respond to treatment long term. And those are the prognostic markers that really mean, that are important to me. So the currently available prognostic markers universally are going to be, ZAP70, which
Mhm.
is a protein on the inside of the cells. And being ZAP70 positive predicts for an earlier time to needing treatment. CD38, which is a protein on the outside of the cells, and that's being positive predicts for an earlier time to needing treatment. Interphase FISH, which looks at chromosomal changes, and those will be either having a deletion of 17p, which is the P is the short arm of the chromosomes, and the Q is the long arm. So chromosome 17p would be the short arm of chromosome 17. Deletion 11q, which would be a deletion of the long arm of chromosome 11. Trisomy 12, which would be 3 copies of chromosome 12. Or a deletion of 13q, which would be a deletion of the long arm of chromosome 13. Or basically normal, which really is none of the above. So there's really 5 different possibilities: normal, 13q deletion, 11q deletion, trisomy 12, and 17p. And those will create 5 different curves that will have different predictions in terms of time to treatment. And those are all called interphase FISH. And then finally, the last one is immunoglobulin gene mutational status. And that basically looks at the immunoglobulin genes and whether or not they're mutated or unmutated. And that just determines whether or not the CLL cell has actually been under the influence of a T cell during its development. And interestingly, being mutated actually has a better prognosis. And the mutated immunoglobulin gene CLL have a much more slower time or a longer time to needing treatment. So those are the prognostic markers that are more universally available, and those will predict for times to treatment. But, when we look at what's going to be really important, out of all of those, really only the 17p deletion, which is one that actually predicts for what's called the TP53 gene, or the p53 protein function, really predicts for how patients do long term with our current novel therapies. So that's the one that really does become important, because if you have a trisomy 12 or you don't have a trisomy 12, you're going to do exceedingly well with the BTK inhibitor. If you have a 17p deletion, you're going to do not as well as if you don't have a 17p deletion. So those are the things that really do matter, and really are things that could factor in to how we should be treating or planning our treatments for our patients.
That really does fill in a lot of questions and blanks for me. So thank you for that. I started off this program by mentioning two acronyms, CLL and SLL. I would like for you to explain to our guests, one, are they the same? And if they're not quite the same, how are they different? And what does it mean when my SLL changes to CLL? I thought this was a great question.
So no one's CLL changes to SLL and vice versa. They're exactly the same thing. And it's just so important to keep that in mind. The whole idea is actually, in retrospect, hilarious. So in 1993, a patient could actually have a lymph node biopsy sent to the pathology department and a bone marrow biopsy sent at the exact same time. And the pathologist would look at the lymph node and say that this is a small lymphocytic lymphoma, or SLL. And then the same pathologist could look at the bone marrow biopsy and say that this is chronic lymphocytic leukemia, or CLL. And it's because anything in the lymph node was a lymphoma, and anything in the blood and bone marrow was a leukemia. But these were the exact same cells with the exact same abnormalities, and they really had two different terminologies and diagnoses for absolutely no good reason. So in 1994, when we came out with a new classification system, which was called the REAL classification system for the revised European American Lymphoma classification system, they just changed the name from CLL or SLL to CLL/SLL. Not very creative, but that's the way they used it. For historical purposes, some of the CLL physicians clinged to the idea that to have a diagnosis of CLL, you needed to have more than 5,000 circulating monoclonal B cells. And so in the peripheral blood. And so that definition still persists. And so you'll see some clinical trials use it. You'll see, even the IWCLL, the International Workshop on CLL, will identify CLL as having more than 5,000 monoclonal B cells in the peripheral blood, and SLL not. But they really are the same thing. And interestingly, you can have CLL get treated and then relapse as SLL. And they're really the same thing. There's no distinction. There's no difference prognostically. And what's really fascinating is we've never been able to really figure out why there are differences. So interestingly, 11q deleted patients do seem to have more bulky lymphadenopathy compared to other interface fish abnormalities. Beyond that, we really can't tease anything else out. And what's also really interesting is, of course, when we take someone who has a lot of bulky lymphadenopathy and give them a BTK inhibitor, and we interfere with the BTK enzyme, we actually interfere with the ability of these cells to hold on in the lymph nodes. And so they do fall out of the lymph nodes and fall into the blood. And you end up with basically taking someone who might have been an SLL patient and making them a CLL patient. But they've always been a CLL/SLL patient all along. So it's an old terminology. It should never be used. And patients are always a CLL/SLL patient. One of the things that's really, I think, important to keep in mind, medically speaking, is that when someone does get diagnosed, like I'll have a patient come in with lymphadenopathy and a lymphocyte count in the peripheral blood of maybe about, 4,000. And, 4,000 lymphocytes in the peripheral blood is elevated. And I know that there might be 2,000, CLL cells in the peripheral blood. And I'll be able to use those 2,000 cells to make a diagnosis of CLL/SLL. But I might not be able to do what's called next generation sequencing and to look for all the mutational profiling for prognostic purposes. So I can't get really a complete prognostic panel from that patient. And so I might not be able to tell about P53 mutation or a Notch1 mutation and all of those different things. And so it's important, like if I have a negative FISH panel or a negative prognostic mutational panel, that I make a mental note and say possibly negative because insufficient cells in the peripheral blood, because there's always a sensitivity issue. And that's where sometimes it gets a little bit difficult. And so it's always important to know how many cells that you're looking at really are CLL cells. And that's just the one caveat. And so sometimes even, you know, that's where when people get these prognostic markers examined, it's helpful to know exactly what the white count is. And I'll even, like, after I give someone a BTK inhibitor, repeat the prognostic markers, because if they have a lymphocytosis, I now know I'll be looking at the CLL cells. But that's sort of the one caveat between a CLL and an SLL patient. I mean, by and large, it's always nice to avoid doing a bone marrow biopsy, and there's no reason to really do a bone marrow biopsy if I can make a diagnosis off the peripheral blood. And, getting those additional prognostic markers usually is not necessary.
Speaking as someone who's had more than a couple of bone marrow biopsies, thank you for saying that they're not always necessary.
They usually are not, and I hate doing them.
Good. I love hearing that. We've talked about what is CLL, SLL. We've talked about prognostic indicators or prognostic markers, and we've talked about criteria for starting treatment. One of the things that I've heard you mention a couple of times are BTK inhibitors. So, two-part question. Are BTK inhibitors the preferred frontline treatment for CLL? And if so, how do you decide which one to give?
So this is it's a very personal question. I guess personal is not really the best word, but it's, everyone has their own biases, the physician and the patient. And that's really, so there is no one best treatment. I do prefer BTK inhibitors for frontline treatment in patients with CLL. And it's for a couple of reasons. And I think that they are more efficacious and safer and better tolerated. But, the downside is that they're often continuous therapy that you need to stay on. Um, but, I think that they're much easier to use. And that's, my own personal bias. A lot of people would rather just have, a short duration of therapy and deal with everything else. So it's really a very personal approach that you have to take. So when we talk about BTK inhibitors, we're talking about basically we're talking about drugs that target Bruton's tyrosine kinase. And Bruton's tyrosine kinase is an enzyme that's present in a lot of different cells. And this is what's really interesting. It's present in B cells, and it's present in macrophages and in platelets and in eosinophils and really many, many other cells, many more than we actually realized. But it seems to be most critical to B cells. And that's what's really so striking. As it turns out, kids who are born without this enzyme have really only a B cell defect, and they have no B cells, and they end up succumbing to infections at a very young age. Now they do quite well because they can get immunoglobulin replacement therapy. But in 1950, there was actually Colonel Ogden Bruton identified these kids as having no immunoglobulins and coined the term Bruton's agammaglobulinemia. Turns out that it's the BTK gene is on the X chromosome, and that's why it became X-linked agammaglobulinemia. They have no protein, and that's why they have a slightly different phenotype. Fortunately for us, we're just blocking the enzyme, but there's still the protein there, so it's not as severe. and our patients do much, much better. The other thing that's interesting is, we block BTK and platelets, but TEC, which is a similar protein, can actually compensate in platelets. So these kids who are missing BTK have normal platelet function because the TEC protein totally compensates. Now, ibrutinib, acalabrutinib, zanubrutinib, and pirtobrutinib, which are the 4 BTK inhibitors currently approved, all block BTK fully, and then they all block TEC to varying degrees. And so because they block TEC, they cause platelet dysfunction, and that's why we get bruising and bleeding. Now, the amount they block TEC is actually what causes the varying degrees of bruising. And so that's why it's sort of interesting. And we've learned now about TEC and platelets only because of what we've seen with the BTK inhibitors. So it's sort of this interesting aspect of it all. And what really makes all this also a little bit more complicated is because we use these drugs at fixed doses. So everyone who gets, 420 milligrams of ibrutinib will have BTK fully inhibited, but TEC won't be fully inhibited. And the amount of TEC that's inhibited is going to be determined by basically how large you are. And so the bruising does correspond to sort of the size of the individual, such that someone who's small will have much more bruising than someone who's large. And so it's almost titratable. And of course, these are all different things that will sort of factor out. And so it's sort of an interesting scenario. And a lot of these things can help impact sort of the choice of your BTK inhibitor. So in general, when we talk about BTK inhibitors, the other big major category is going to be a BCL2 inhibitor or venetoclax. And there's a new one called sonrotoclax, which is coming very soon. And the BCL2 inhibitors work differently in the sense that they actually target the BCL2 protein and really cause a great deal of, basically, they cause the mitochondria to collapse and they cause the cells to actually undergo cell death very rapidly. So whereas the BTK inhibitors, by targeting BTK, can cause, the way I look at it is, ibrutinib, which is the first one, causes typically, bruising and diarrhea. It can cause joint aches and hypertension, atrial fibrillation, and nail and hair changes. And then you can have the second generations, which actually cause fewer problems. So acalabrutinib causes basically bruising and headaches. And you have zanubrutinib, which can cause really just bruising and hypertension, and maybe a little bit of neutropenia. And then pirtobrutinib, which causes pretty much just bruising. The BCL2 inhibitors really just cause tumor lysis and thrombocytopenia. And so it's a slightly different problem because the tumor lysis is something that happens very quickly and can be dangerous and just needs to be monitored very quickly. And so it's a matter of sort of choosing sort of the side effects and the monitoring that's required, because the venetoclax will require a lot of monitoring very early on when you administer it, because you have a lot of potential tumor lysis that occurs. Whereas with the BTK inhibitors, you can just give someone a pill and say, I'll see you in 3 months. So it's sort of those differences that allow for people to be treated very differently. Overall, I think that the big differences between them also factor into the sense that besides the risk of bruising and bleeding for the BTK inhibitors, which don't exist with venetoclax, which is, I think, the one big thing that helps me decide between one category and the other, and the continuous therapy for one versus typically the year duration of therapy for the venetoclax. It's really just the patient's desire to whether or not they want to be on a long-term therapy or not. So those are really the big decisions that I think factor into that.
Very good. The BTK subject, we've received a lot of questions. You mentioned atrial fibrillation, and speaking as someone who was literally just at the cardiologist last week, are there concerns about these drugs in cardiac patients?
Yeah, so one comment in general, which I did want to make is, when we look at the package insert and as you see on advertised on television, whenever we do a clinical trial, everything that happens to a patient has to get included in the package insert. So if someone got hit by a bus crossing York Avenue on the way to my office, the package insert for that drug will say taking this drug could cause you to get hit by a bus. And it's important to recognize that, you know, when we talk about these drugs, as the investigator, I know what is drug related and what's not drug related, but that's not what goes in the package insert. So there's always a background incidence, and it's always hard to discern what might be real and what might not be real. It's also important to distinguish, you know, a lot of these drugs have, when they're especially head-to-head studies, differences in time on treatment. So like the bendamustine rituximab versus the, acalabrutinib study, patients were on bendamustine rituximab for 6 months, but on acalabrutinib for 5 years. So having 5 years of follow-up is going to generate far more adverse events compared to just 6 months. So these are all things that get lost in the follow-up. But in general, atrial fibrillation is sort of the important one because that really has a lot of issues in terms of the risk of anticoagulation and cardiac problems and so forth. So ibrutinib absolutely does cause an increase in atrial fibrillation. And the numbers are, of course, hard to pin down because there is always an incidence in the older population. There was a very good study done out of the Mayo Clinic, which says in a general population of people needing treatment for CLL, it's probably going to be about 5 to 7%. In patients on treatment for ibrutinib, it's probably going to be about 15 to 17%. So it is about a threefold increase. When we look at acalabrutinib and zanubrutinib, it's looking like it's actually going to be around the 5 to 7% range. So we don't think it's increased for those, but it's, always hard to tell for certain, but it's definitely increased for ibrutinib. Interestingly, hypertension also definitely increased for ibrutinib, definitely increased for zanubrutinib as well, but not as much for ibrutinib, and not increased for acalabrutinib. And so that's also a cardiac issue that, is something that should be accounted for as well. Pirtobrutinib does not look like it causes either atrial fibrillation or hypertension, which is also something nice to see and is something that should be considered as well.
So it sounds to me like once again, we have to remind patients and their caregivers, be candid with your care team. Let your medical professionals know what's going on. If you have a history of hypertension, if you have a history of cardiac issues, that information needs to go into your matrix to help make better decisions. Is that a fair statement?
Absolutely. And I really think, a lot of physicians will get comfortable with something and not switch. And I think that's really a bad thing to do. And, I actually, started prescribing ibrutinib in 2009 or 2008 even. And I have not prescribed ibrutinib since 2019 now. It's important to evolve, and we have better agents now, and it's important to recognize that. Um, and I think that, a lot of patients who are on ibrutinib might do better on some new drugs, and, people are afraid to try different things. And, listen, a lot of the things that's important also is a lot of these adverse events happen early on. So if you've been on a drug for 5 years and you're fine, you very well may just be fine. And that's important too, right? So it's hard to know. We do know that when we look at studies, the adverse events cardiac wise with ibrutinib were seen predominantly in people over the age of 70. So that's another thing to take into account as well. So there's a lot of differences, and I know the pragmatic issues related to some insurances only wanting to pay for ibrutinib versus, zanubrutinib. And, so it's always hard to sort of figure out which battles you have to fight. It's nice to have choices, and, we'll have more choices in the not too distant future.
I'm going to hold you to that. One of the things that I have witnessed in my 14, almost 15 years of CLL is that when I started, there wasn't a whole lot to choose from. And now that there's so much to choose from, and hearing doctors like yourself say, and there's even more coming. So I'm holding you to that because I personally want better treatments with less toxicity that are more effective. I want it all and I want it now.
So I think I heard that song. But the one thing that I just want to add to what we were talking about earlier, and I think that's really more important, is, not just whether or not it's a BTK inhibitor or whether or not it's a BCL2 inhibitor, but these combinations. A
Mm-hmm.
lot of, like, my worldview is that 80% of patients with CLL have genomically stable disease and will do exceedingly well with just a single agent BTK inhibitor and not need anything else. 20% might have the ability to evolve and behave a little bit more difficult, a little bit more aggressively. And they will be well controlled with just using a combination of agents. Now, I do think the anti-CD20 monoclonal antibodies are, you know, they're a little tough on the immune system because they knock out the normal B cells and they kill your immunity, and they'll actually destroy your, responses to prior vaccinations. But you know what? If you were to use, instead of a venetoclax plus a obinutuzumab, if you were to use venetoclax plus a BTK inhibitor, all of a sudden you preserve your prior immunity, you get the two agents that are synergistic and, take care of what you need to. And so it's sort of like, we've done the figuring out and we have the tools available to us. And that's really the important thing. So, we have what we need, and it's really sort of a very, you know, and I think, I'm very risk adverse, and that's why I sort of like avoiding the anti-CD20s and taking advantage of all these great new agents.
That sounds great. I want to shift lanes because I'll share with you, coming up on Friday, I am headed off to a birthday party for my uncle. He is the last uncle that I have on my father's side, and we're all looking forward to celebrating time with him. My uncle also has CLL. What's the current research on genetic risk factors for CLL? And is it familial? Is it just chance? Is there something going on here?
So CLL is a fascinating disease. And, the one thing that we know about CLL, it has a tremendous ethnic predilection. So there's no CLL in Japanese and Native Americans. And as you move west across Asia and into Northern Europe, the incidence increases. The incidence is probably about 4 per 100,000 in Northern Europeans. But what's interesting is the incidence actually is double in Ashkenazi Jews. So it really does follow ethnic, it segregates along ethnic lines, which is really quite interesting because, ethnicities segregated about the same time the human leukocyte antigens evolved. And those are the proteins that determine how the immune system sort of recognizes self and non-self. And it's sort of like, when we do bone marrow transplants in patients, we always look in the same ethnic group. And that's because we need to match those HLA proteins. And so I've always taken this to sort of imply that the HLA proteins are probably sort of a predecessor or a predictor or a necessary risk factor for the development of CLL. And so, all the Ashkenazi Jews are going to have closer HLA proteins to each other than they will to, than people who are, of a different ethnic group. And so it's sort of, that similarity that sort of enables everyone to sort of have that same risk factor for developing CLL. Of course, an uncle and his nephew are going to be far closer in their HLA match than, two distant Ashkenazi Jews. So it's, that sort of thing as well. So that's sort of how I put together the genetics. It's not a gene like blue eyes where you have, a couple of different choices and you either get it or you don't get it. You know, HLA is probably a 45 different gene process, and you inherit all these different genes in a certain combination. And then you need to have all those genes get turned on in a certain manner, and then a certain stimuli to that cell has to occur. So it's a lot of different things that must occur. And since you have billions of lymphocytes, it probably can occur if you live long enough. And that's the other thing is, they say 3 to 5% of the, US population is walking around with CLL cells at extraordinarily low levels in their blood. We just, need special techniques to detect them. And so it's sort of that type of thing that if we all lived to 120, CLL would be quite common. And so it's
Indeed.
sort of that type of scenario, and that's sort of the genetic connection. So I don't want people to panic. I think there's just two more things to say this. When they look in Mexico, where there's still a large Native American population, the incidence of CLL is 0. And there's still a large pure Spanish population, and the incidence of CLL is equal to that in Spain. And then there's all those people who are interbred, and the incidence there is actually right in the middle. So it's sort of a blendable trait. And then when we look at environmental factors like radiation, so after World War II, there was no increase in CLL in Japan after the atomic bombs. And so they assumed that radiation was not a risk factor for CLL. But of course, that was on a non-permissive population. When they looked around Chernobyl, of course, there was a spike in CLL. So radiation on top of a permissive ethnic population did lead to an increase in CLL. So it's sort of a very interesting interplay of a lot of different factors.
So there's lots of layers to that onion, as it were. I'm going to ask a question in regard to supplements. A lot of people are very enthusiastic about adding supplements to their regimen. Some of them can have great effect, some of them can have no effect, and some of them can actually be hazardous to not just CLL patients, but people in general. Let's start off with one that I hear all the time. Does vitamin D play a role in CLL outcome?
So the vitamin D is a very fascinating topic, and I'm actually, a very big believer in vitamin D because, when we look at the morbidity and mortality in our population, osteoporosis is probably the number one cause of morbidity and mortality. And, I don't know if vitamin D is the answer for osteoporosis, but right now it's the one thing we can impact upon. So they did some studies and they showed in CLL patients that, those who had lower levels of vitamin D did have more aggressive courses and worse outcomes. And so originally I thought that maybe vitamin D may predict, lower vitamin D levels may predict for more, for a worse outcome. But, it's hard to supplement because then, of course, everyone was taking vitamin D supplementation because, this was actually then everyone figured out about vitamin. What happened is for so long, we couldn't measure vitamin D levels. And so there was this period of 5 years when they then started measuring vitamin D levels. And the other thing about this study that was done, and this was done at the Mayo Clinic in Rochester, Minnesota, the impressive part of the study was they found that 70% of the people they assessed were vitamin D deficient. So we're talking about massive amounts of vitamin D deficiency. So all of a sudden, oh my God, everyone's vitamin D deficient. So, it's a real problem because we just got to replete everybody anyway. So, it's sort of the type of situation where, all right, so let's replete everyone to what would be considered to be, 30, and I think it's nanograms per ml became the target for shutting off PTH and helping to prevent osteoporosis. And, that showed to actually help prevent worsening osteoporosis. But it didn't really seem to have any of the other benefits that people started touting about, decreased cancer risk and all those other things. So I advocate for vitamin D, getting people's levels over 30 only because of the prevention of osteoporosis, nothing to do with CLL. But that's how it got really stuck in everyone's minds about CLL. The Mayo Clinic did try to do an intervention study where they gave people vitamin D and versus placebo, but the study actually never got done because they found everyone was just taking vitamin D.
Wow. Um, I believe in vitamin D and getting it naturally, but I also know that as a CLL patient, I have a higher risk of skin cancer. So I'm the one wearing the floppy hat and the long sleeve shirt and hoping that I get enough sunlight to help me, but not hurt me. Question mark?
Well, but you probably couldn't ever get enough vitamin D from sunlight, period. I
So
mean,
drink more milk and consider a supplement, right?
well, it's interesting. The lowest vitamin D level I've ever seen was in probably one of the healthiest women, I imagine. I mean, she ran, you know, 75 miles a week. She only ate organic foods. I mean, she had no supplement, nothing she ate was processed. And the only way vitamin D gets into our diet is by processed foods. And there's also a famous New England Journal paper about a woman who, ended up with a disease called Wernicke's encephalopathy because she had no thiamine in her diet and she developed cholecystitis or a gallbladder attack. And, she was put on IV sugar or dextrose and ended up developing this because she had, only alcoholics get Wernicke's because they can't absorb thiamine because of the alcohol. But because she was eating no processed food, she had no thiamine in her diet because it's only put in processed foods. It's funny. I mean, you have to be careful. There's a lot of things that get into our foods only because we put them there. Because, you know, evolution never thought about the fact that we needed to have, bone health into our 70s. And that's the problem.
Indeed. While we're talking about supplements, I've got a list that's been added here. Things like EG, olive leaf, reishi, resveratrol, and other supplements. I know that there's a lot of enthusiasm for adding the extras to diet. Is there any tangible benefit in your opinion?
None. And I really have to emphasize that. And I really actually have seen harm in quite a few circumstances. And I really can't emphasize that. I mean, enough. You know, they did a study from ECGC, and the amount of basically green tea that you would need to take to get to the doses that they used is extraordinary. And actually, there are a lot of problems with LFT abnormalities and so forth. And certainly, the treatment was far less well tolerated than any BTK inhibitor. But, the benefits were actually far lower too. So why not just take the BTK inhibitor? But with all the others as well, like resveratrol, which is in red wine, and all these other things, they work in the test tube, but of course they don't work in the body. And it's, important to recognize that, all these supplements, there was a change in the laws in 1990s where anything that's considered to be a supplement didn't have to substantiate their claims. Just like Tony the Tiger can say that Frosted Flakes are great without proving it in a randomized controlled clinical trial. So these supplements can actually make these same claims. And that's what spawned this whole industry. And the problem, of course, now is that people have, you know, been fooled into thinking that these are true claims. And they also don't have to market or list what really is in them. And there's some reports of people who have been taking roots for energy that have been laced with amphetamine additives and caffeine and other stuff too that can be dangerous. But none of these have actually have been shown to have any benefit whatsoever. And I've seen people, St. John's wort actually degrades the BTK inhibitors by activating the CYP3A4 enzyme. So anyone who doesn't respond to a BTK inhibitor, the first question I ask is, you've got to stop what supplements are you taking? Because, a lot of these supplements will have St. John's wort in it, and that will destroy the BTK inhibitors.
Wow. We've kind of danced around the very large bear in the room. A couple of years ago, this unwelcome guest showed up to planet Earth by the name of COVID. And COVID absolutely is a serious health situation that has affected millions and millions of people, especially those who are immunocompromised. Let's take a few moments to talk a bit about COVID. We've got things like, is there a role for half dose COVID? How worried should I be about traveling? Should I mask? I'd like you to address the COVID situation from both a clinical standpoint and a practical standpoint.
I mean, I really feel that COVID has evolved into so much more of an innocuous disease now that people could resume normalcy. And life has to go on. And we also have Paxlovid now. And so I do advocate for people to just rejoin society, is the expression that I use. If someone does get COVID and we need to do something, we have Paxlovid.
Um, yes, I'm agreeing with you because for some strange reason, I managed to avoid COVID for a very long time until just this past January. I got COVID. I asked for Paxlovid. I got Paxlovid, and I got better. And I'm living my life. I know that there are people that are still very, very concerned. Is there any situation where they should take extra precautions?
I really don't think so. And I really think that a lot of people are very worried. And the truth is, you know, everyone has to decide for themselves. But, I think by and large, we're not losing people to COVID. And that's sort of the important thing to keep in mind. I've had a few patients who have developed long-term complications like a bronchiolitis obliterans, where it's a inflammation of the lungs, but we get people through that as well. And so at this point in time, people could resume normalcy. Now, I'm a big advocate for vaccines, and I do believe the COVID vaccines are safe. And anytime you vaccinate 350 million people simultaneously, you're going to have issues develop. Um, I do recommend getting vaccines every 6 months and, just continue to vaccine people. I don't recommend half dose vaccines because I think obviously, the vaccines are only tested at full dose. And we don't know if CLL patients are going to respond to the full dose even. So why use a lesser dose? Measuring antibodies is always an important question. And we know that the T cell response is probably the more important part of the vaccine. So antibodies never really even predict for protection. So I don't even bother measuring the antibody response. So I just recommend vaccinations every 6 months. Good hand washing, not touching your eyes, nose, and mouth is always the best answer because that's how most people are getting infected. And it's just about being smart in those regards. I mean, travel on a plane is fine. When people travel, it's usually the jetway and it's usually the small rooms that people are getting infected on. The plane itself, the air exchange is actually quite good. And it's the virus accumulating in the room and then you breathing in that air that causes the problem. The air circulation on the plane is actually good enough that you're not getting sick on the plane. So it's stuff like that. And I think you know, it's okay just to, go out there. Um, listen, there's the RSV vaccine, which I think everyone should also be taking. And, I do recommend doing Prevnar 20 and Pneumovax 23 and Shingrix and all those vaccines. But, people can do really quite good with everything. Now, the one other thing everyone always worries about is, this Paxlovid or COVID rebound or Paxlovid rebound. And I don't think that is really as bad as people make it out to be. And if you remember in the beginning, we used to always talk about how people would sort of putter along for 2 weeks and then get really sick. So what most of the Paxlovid rebound is really the people who took the Paxlovid during that first 2 weeks and then got sick really at the 2 week mark. And, as it turns out, only about 5 to 7% of patients have a real rebound when you do it, looking at the actual viral proliferation. And the worst case scenario is you just take two courses of Paxlovid. So it's not really a big deal.
It tastes a little nasty, but it's not a big deal.
Right.
So tell me about Pemgarda.
So, it's interesting. I mean, it's another monoclonal antibody. It's administered intravenously every 3 months. It's meant to help protect against symptomatic COVID. It's not meant to be used in people who have COVID or have been exposed to COVID. So it's not a pre-exposure prophylaxis. I actually not sure it's yet commercially available. Last time, it was still, it's approved. It's not fully approved. It's just an emergency use authorization. So it hasn't gotten full approval yet. So it's still considered to be experimental. Um, so obtaining it is still hard. I mean, on the website, you can actually go to find out where it's being administered, but it's not something that's being universally distributed. I'm not so sure that, its benefits are there. Remember, a lot of the benefits are going to be measured in its ability to prevent people to be hospitalized, but there's so few people being hospitalized that, it's sort of hard to measure a benefit.
Interesting, interesting. I've got a question here that, well, a lot of the questions have hit me rather personally. For patients with chronic sinusitis, what interventions are likely to be of the most help? And I say that as someone who had the balloon sinuplasty and the deviated septum thing fixed. And for the first time in 35 years, I can actually breathe through my nose well. So I feel the pain of chronic sinusitis. Can you help us?
Absolutely. So common things occur commonly. That is always the first rule in medicine. And the most common cause of a chronic sinusitis in any patient, even a CLL patient with hypogammaglobulinemia, is going to be, a deviated septum. It's going to be, polyps. It's going to be basically just crud blocking the flow of sinuses. And so, it's basically the sinuses are channels inside the skull bones. And when, the mucus basically can't flow, the bacteria basically grow and cause inflammation and pain and infection. So, antibiotics are going to kill the bacteria, but if the bacteria can't get out, they're just going to regrow again. And the immunoglobulins do play a role in helping suppress those infections. But if you're hypogammaglobulinemic, you're certainly more sensitive to having those bacteria take hold. But even if you have antibodies and you still have obstruction, you're just going to get stuck with chronic sinusitis. So my general rule, and CLL patients who are hypogammaglobulinemic are definitely more at risk of having chronic sinusitis, chronic bronchitis, recurrent pneumonias, and even life-threatening infections. But the idea is that the first step in helping anyone who's having any of those issues is to make sure, using through an ENT, is that you address the anatomical abnormalities. And so I always have, make sure the channels are open, make sure there's not a polyp, make sure there isn't a deviated septum, making sure that there isn't an allergic component. So if there is an allergic component, something like a daily antihistamine or nasal steroids could sufficiently calm the inflammation to help the flow start. The next thing is to make sure something like a neti pot or some nasal irrigation, just to keep, the channels open, is also a very good start. And those are things that can really sort of, by keeping the mucus down, will help prevent the infections from building. Now, if someone's continuing to have recurrent symptomatic sinusitis, IVIG can be very helpful. And, IVIG is extremely well tolerated. The only downside to the IVIG is it's a hassle. So it's typically a 3-hour infusion every 4 weeks. It's well tolerated. It's just, you have to sit there for 3 hours every 4 weeks. It only works while you're getting it, but sometimes patients can get it for 6 months and you'll have like a healing of the sinuses, and maybe then you'll be able to stay free and clear. Some people really just need it during like the spring when their allergies really kick in, and it sort of will protect them when things are worse. So there's ways that we can try to make it as you know, not as cumbersome for the patient. And that's something that can be really helpful for patients. I have some patients who really run into trouble, and we do things like add antibiotics to their nasal rinses, or we'll give them nebulizers. When the nebulizers, you basically aerosolize the antibiotics and they breathe it into their sinuses to try to reduce the bacterial load. So there's a lot of things that we can do to try to minimize it. But for patients who have real bronchitis or pneumonias, or life-threatening infections, they'll have low antibody levels and just need to have those antibodies systemically. They're ones who are just getting the IVIG anyway, and for them, it's obviously could be life-saving.
Fantastic. Dr. Furman, this has been great. I started off the presentation by saying we're going to get to all of the questions, and as it turns out, I wasn't 100% candid. We did not get to all the questions. I hope that you'll come back and join us again.
My pleasure. I would love to.
Before we close the program, do you have some closing thoughts for our audience?
Yeah, I really think, from my perspective, we have so many great treatment options for CLL patients. And I really think, in 2024, no one should die from CLL, and that everyone should hopefully be able to enjoy normal longevity, and just avoiding things that are going to impact upon quality of life is the most important thing. No one should ever get chemotherapy, and I do know there are some physicians out there still using chemotherapy, and I really have to, argue or try to persuade people to make sure you avoid it. I do have a huge bias against anti-CD20 antibodies, and I know that's not something shared by all my colleagues, and I definitely know that I know enough to know I don't know everything, and that's my bias. But it's sort of the idea that preserve the immune system and to keep people as healthy as possible. But it's we're not trying to cure people. We're just trying to get people to live to 100 and just have wonderful lives. And sometimes just making it simple is really all that's necessary, and I think we can do that.
Those are great words. Thank you so much for your time and for your expertise.
Pleasure.
We are very, very grateful. Yes, we are grateful for your participation. I'd also like to thank everyone who joined us today. I'd like to thank our generous donors to CLL Society and grant support from AstraZeneca, Beijing, and Genentech just for making this event possible. A few brief reminders: if you're a Facebook user, please remember to like and subscribe to the CLL Society Facebook page. This is an important part for me. Please complete the short event survey linked in the comments section on Facebook and will be shared with everyone who registered. We really want to hear your feedback. If we don't hear from you, we don't know how to make this even better. Please join us on August 7th for CLL Society's next webinar, A Brighter Future for CLL. Learn how your legacy can have a lasting impact. If your question wasn't answered today, please send it to our Ask the Expert email service. This is a free service and can be found on the CLL Society website under Programs and Support. Please remember to follow CLL Society on Facebook and on other social media platforms. Lastly, CLL Society is truly invested in your long life, and you can invest in the long life of CLL Society by supporting our work. Thank you very much for your participation, and remember what I tell everyone: people who take an active role in their own care have better outcomes. Thank you.